Next topic is filariasis. So the filariasis causative agents are the lymphatic filariasis that is caused because of Escherichia bancrofti, which is the most common causative organism. Apart from that, Brugia malai, Brugia thimori. Then subcutaneous lymphatic filariasis that is caused because of Loa loa, which is African eyeworm, Onchocerca volvulus, which causes river blindness, and serous cavity filariasis, that is Marsonella species. Now, the transmission. It is a mosquito-borne infection that is transmitted by Culex mosquito Anopheles aedes, which serve as the vectors. Infective stage is going to be the L3 larva, and no direct person-to-person transmission happens. The life cycle. In the life cycle, the human host, the larvae mature into adult worms in lymphatic vessels and they produce microfilariae. Microfilariae, they circulate in the peripheral blood. Mosquito vector, it ingests the microfilariae during the blood meal and develops into the infective L3 larva, which enters the human beings. Now, clinical features, it is asymptomatic in the initial phase. Then subclinical lymphatic damage happens. Next is the acute phase. In the acute phase, it leads to acute adenolymphadenitis. It causes fever, painful lymphadenitis in the inguinal and axillary region. Then the next is the dermatolymphangioadenitis, that is inflammation of lymphatics as well as the skin. And lastly is the filarial fever, where recurrent febrile illnesses, the episodes, they happen without local signs. Then the third is the chronic phase. So in the chronic phase, there is going to be lymphedema, that is, which progresses to elephantiasis, where it involves the lower limbs, scrotum. Then the hydrocele, that is the most common chronic manifestation in case of male. Chyluria, that is chylous urine that is passed due to the lymphatic rupture into the urinary tract, and tropical eosinophilia is seen. Then diagnosis on the blood smear, you will find microfilaria in the nocturnal blood. Antigen detection is by card test for Escherichia bancrofti. PCR can be done. On the ultrasound, we can see the dancing bone sign, and eosinophilia is also present. Management. For the management, diethylcarbamazine, that is DEC 6 mg per kg per day for 12 days is the drug of choice. Apart from that, ivermectin and albendazole can be given as annual mass administration. Doxycycline 200 mg per day for 4 to 8 weeks can also be useful. Supportive care for lymphedema management, elevation of the limb, compression bandages, skin care, antibiotics, and prevention of secondary infections. In hydrocele, surgery is done if it is large and symptomatic, and chyluria means a low fat diet and sclerotherapy is taken. For prevention and control, mass drug administration, that is annual diethylcarbamazine, ivermectin, or albendazole is given. Vector control by insecticide, treated bed nest or larvicidal measures. Personal protection by mosquito repellents and morbidity assessment. Then global status is, it is to be eliminated as a public health problem by 2030, and India is one of the countries where it is endemic, and high burden states in India are Uttar Pradesh, Bihar, Jharkhand, and West Bengal. Complications are secondary bacterial or fungal infections, then genital damage leading to infertility, scrotal lymphedema, social stigma, and renal damage. The special notes: the endosymbiont. Endosymbiont is a target for the doxycycline therapy, and because of which this organism dies. And tropical pulmonary eosinophilia, which is a hyper responsiveness syndrome to microfilaria. And for prevention of disability, we should prevent the progression to elephantiasis. Then next is the chickenpox. So the chickenpox, the causative agent is going to be the HZV3, that is human herpes virus 3, virus 3, or the varicella zoster virus. Primary infection, it leads to chickenpox, and reactivation, it leads to shingles. The transmission is by the droplet infection from the respiratory secretions or direct contact with the vesicular fluid. It is highly contagious in nature, and the incubation period is about 10 to 20 days. The clinical features are: there is a prodromal phase where mild fever and malaise is present, and the rash. The rash starts on the trunk first, then goes to the face and then the limbs, and it is centripetal in distribution. The lesion progresses as macules, that is hyperpigmented lesions, then papules, vesicles, pustules, and then the crust. All the stage they are present simultaneously in a particular individual, so that is a polymorphic rash is present. Then mucosal lesions or enanthem in case of mouth and conjunctivitis is common. Then complications can lead to bacterial superinfection with staphylococcus or streptococcus, leading to cellulitis or abscess. Then pneumonia can happen, Apart from that, the neurological manifestations can be encephalitis or cerebellar ataxia. Rage syndrome is aspirin is taken along with it, and hemorrhagic chickenpox in case of immunocompromised individuals. Then the diagnosis, clinical diagnosis by the characteristic rash. Apart from that, Zank smear is taken for the herpes virus, and PCR can be done or serology for varicella zoster virus. Management, for symptomatic patients, antibiotics are given, but however, avoid aspirin. Then antihistamines for itching, calamine lotion, and antivirals, that is acyclovir. If taken, it should be taken within 1 to 2 days of the rash. So acyclovir 15 mg per kg for 5 times daily for 5 to 7 days. So acyclovir should be taken 5 times a day for 5 to 7 days, and it is indicated in adults, immunocompromised, and pregnant women. Isolation should be done until all the lesions they are going to be crusted, and treat the bacterial complications with antibiotics. Prevention, vaccination. There should be a live attenuated vaccine, that is varicella vaccine. Then post-exposure prophylaxis. Immunoglobulin is given. Varicella zoster immunoglobulin should be given within 3 days. And antiviral prophylaxis is in exposed immunocompromised. And talking about the measles, so measles is also called as the rubeola. Causative agents is the measles virus, that is Paradoxoviridae, which is a RNA virus, highly contagious in nature. Then transmission is by respiratory droplets, infectious 4 days before rash and 2 days after the rash. So the incubation period is about 10 to 20 days in this. Now in the prodromal phase, there is again a few 3 seasons: cough, coryza, conjunctivitis, and fever. Then the enanthem is going to be the complex spots, which are pathognomonic of it. These are the grey white spots which is found on the palate. Then exanthem is the maculopapular rash, which starts behind the ears. Then it involves the face, then trunk, and the limbs, and it lasts for 4 to 7 days. Complications, it can lead to common complications. Most common complication is going to be otitis media, pneumonia, right, diarrhea. Severe complications, encephalitis. The encephalitis or SSP, that is late complication, that is subacute sclerosing panencephalitis. High risk groups are the malnourished children, immunocompromised, and vitamin A deficient. Diagnosis. The clinical diagnosis can be made by complex spot and the rash, pattern of rash, then the serology by immunoglobulin M ELISA, and viral PCR for the throat swab or nasal swab. Then management. So supportive management is by hydration, antibiotics, and vitamin A. Vitamin A supplementation, it is 1 lakh international units, 6 to 12 pills, or 2 lakh international units if it is more than 1 year. Then ribavirin is given for severe cases in immunocompromised. Prevention, MMR vaccine at 12 to 15 months and at 4 to 6 years. At post-exposure prophylaxis by human immunoglobulin within 6 days. And isolation of cases is important. Then next is the rubella or the German measles. So the causative agent over here is going to be the rubella virus. Rubella virus, it belongs to Tobaciviridae family RNA virus, and transmission is again by the respiratory droplets. It is highly contagious in nature. The incubation period over here is 14 to 21 days, that is 2 to 3 weeks. The clinical features are: there is a prodromal phase wherein mild fever, headache, conjunctivitis, lymphadenopathy can be present. Post-auricular lymphadenopathy is present. The rash over here, it is pinkish red macules. They start on the face, then the trunk, then the limbs. The Forsheimer spots are seen. Forsheimer spots are the petechiae that are seen on the soft palate. And arthralgia or arthritis, it is common in females. Now the congenital rubella syndrome. The congenital rubella syndrome is also the triad of deafness, that is sensory neural hearing loss. Along with that, cataract is present, and congenital heart disease. The most common is going to be patent ductus arteriosus, followed by the pulmonic stenosis, and followed by vertical septal defect. Other complications are microcephaly, mental retardation, hepatosplenomegaly, and a special rash that is called blueberry muffin rashes present. Then the complications are arthritis. In case of females, most commonly thrombocytopenia, and congenital rubella syndrome infection happens in first trimester. So it leads to a lot of fatal defects. Then diagnosis, it is clinical in epidemic settings. And serology, rubella specific IgM, which is acute infection, IgG seroconversion, PCR for viral RNA and swab culture. Then management, supportive management, that is rest should be taken, fluid should be taken. No specific antivirals are required for rubella. Isolation during this period. Prevention can be the MMR vaccine, which is given at 15 months at 4 to 6 years, and avoid pregnancy for 3 months post vaccination is very important. Prenatal screening should be done. Viral hemorrhagic fever. Viral hemorrhagic fever are the group of severe systemic illnesses, and they are mostly commonly because of the RNA viruses that lead to acute febrile illness, widespread vascular damage, and because of the increased vascular blood membrane, bleeding manifestations are seen. This can lead to shock and multiple organ failure, and many are arboviruses or zoonotic. So the multiple agents that can lead to viral hemorrhagic fevers are the Flaviviridae family. Inside the Flaviviridae family, we have the most common, that is the dengue. Then apart from that, yellow fever virus that causes hepatitis as well as hepatitis. Casanur forest disease, which is a tick-borne. Then Bunyaviridae family. In the Bunyaviridae family, there is hantavirus, which leads to cardiopulmonary syndrome. Then there is a Crimean Congo hemorrhagic virus, Rift Valley fever. Arena virus, there is a Lassa virus, and Filoviridae, there is Ebola virus, which is often fatal. Clinical features is acute onset of high-grade fever, chills, myalgia. Then hemorrhagic manifestations are petechiae, purpura, then mucosal bleeding in the form of epistaxis, gum bleeding, GI bleeding, hematuria, vascular leakage syndrome. It can lead to cerebral edema as well, and decreased perfusion to the brain, pleural effusion, ascites. So these are the things that should be seen under ultrasound, especially in case of dengue shock syndrome, multiple organ involvement, so that can lead to hepatitis, renal failure, myocarditis, and high mortality. Severe forms like severe dengue shock syndrome, dengue hemorrhagic fever, Ebola virus. And then the pathogenesis, there is endothelial dysfunction, increased vascular permeability, plasma leakage leading to hypovolemic shock. Apart from the thrombocytopenia is seen, coagulopathy is seen, immune activation and cytokine storm, and direct viral damage to the hepatocytes leading to hepatitis, that is seen in yellow fever, and hantavirus, that is going to be a cardiorenal syndrome wherein the kidney is going to get affected. Diagnosis is by clinical suspicion based on the bleeding manifestations, and laboratory findings will show thrombocytopenia and increased hematocrit in case of dengue. Elevated liver enzymes is seen in case of yellow fever, prolonged vitreoretinity and also be seen. And then serology, IgM, IgG, ELISA, molecular methods for viral RNA, that is RT-PCR, and antigen detection in case of dengue is NS1 antigen. And leptospirosis. So leptospirosis is caused because of Leptospira interrogans, which is a pathogenic spirochete, right? Then the synonyms for leptospirosis can be Cane-Field's fever, Wills disease, and Swineherd's disease. Now the transmission is by the direct contact with the urine or the tissue of the infected animals like the dogs, rodents, or livestock. So it is generally given in the question that a farmer working in the rice paddy fields or someone in the gutter, right, they get this virus. The entry is via the abraded skin of the mucous membrane. Ingestion or inhalation of contaminated water can also happen. Incubation period is about 1 to 2 weeks. Then this is going to be a biophysical illness. So the first phase, that is called as the leptospiremic phase, which is seen during the first week. Here just fever, chills, rigor, then myalgia in the calves, thigh region, then headache, that is retroorbital headache, or occipital headache, conjunctival suffusion is seen, and nausea, vomiting, and abdominal pain. Now many of these uh, things, they are many of the people, they have only this first phase, that is leptospiremic phase. Now here, as I said, conjunctival suffusion, that is redness without discharge, this is going to be a pathognomonic feature. Now immune phase that starts from second week onward, not seen in all. Here in aseptic meningitis can be present, and Wills syndrome. So Wills syndrome is a hepatorenal syndrome where jaundice will be seen because of acute hepatitis. Renal, it will lead to renal failure. Then hemorrhagic manifestations can be present in the form of petechiae, purpura, epistaxis, hemoptysis, and pulmonary, it can lead to ARDS, and cardiac, it can lead to myocarditis. So multiple organs are getting affected. The diagnosis, leukocytosis is seen. The CPK levels very important, they are found to be elevated. Then in the liver, HOD/SGPT ratio will be increased. Then in the renal, the creatinine in or blood urea nitrogen, that is KFT, is going to be deranged. Then CSF, it will show lymphocytic pleocytosis because of aseptic meningitis. Gold standard is going to be the culture of this organism. So we can use the blood or CSF in the first week and urine after the second week for culture. Then very important serological, that is microscopic agglutination test is used, and IgM, ELISA. PCR can be done, and the criteria for the clinical diagnosis is called as the modified Fiennes criteria. Clinical treatment. So we can use doxycycline 100 milligrams BD for 7 days in case of mild disease. In case of severe disease, we require penicillin G 1.5 million international units, IV 6 hour day is required, or ceftriaxone 1 gram IV is given. Supportive If it's a case of renal failure, then dialysis is given. ARDS, we can go for mechanical ventilation, that is oxygen support. In case of bleeding or thrombocytopenia, we can go for blood products and corticosteroids for severe forms. And herpes zoster virus. Herpes zoster virus, that is the shingles, it is an acute a viral infection that is caused because of the reactivation of the varicella zoster virus, and it is a painful vesicular eruptions that lie along a specific dermatome. Now, pathogenesis is the virus remains latent in the dorsal root ganglia after the chickenpox, and reactivation it happens with aging or immunocompression. Now, the clinical features. Is a severe burning pain along a dermatome. It affects along a dermatome. Then a painful crooked vesicular rash is presented, is generally unilateral in nature, and most commonly it is a thoracic dermatome. Then complications there can be post-traumatic neuralgia for which gabapentin or pregabalin is given. Ophthalmic zoster, it can lead to blindness and secondary bacterial infection. Management is by acyclovir 5 times a day for up to 7 days, and once acyclovir analgesics can be taken. Next is the mumps. So mumps is acute viral infection which is characterized by painful swellings of the salivary gland, making mainly the parotid gland. It is caused because of mumps virus, that is paramyxovirus, and the mode of transmission is by the respiratory droplets or direct contact with the saliva. Clinical features are there is a fever, a painful parotid gland swelling is seen, apart from the difficulty in chewing and malaise. Complications, it can lead to orchitis, pancreatitis, meningitis, and deafness. Sorry, orchitis, pancreatitis, meningitis, and deafness. In case of females, it affects the fallopian tubes and ovary. Management is mainly supportive. Analgesics and antibiotics, adequate hydration is required, and the prevention is by the MMR vaccine. Hookworm infestation. So hookworm is a helminthic infestation of the intestine by the hookworm. It leads to chronic blood loss and anemia. So the etiological agents are Ankylostoma duodenale and Nectar americanus. Ankylostoma duodenale is an old worm infection, while Nectar americanus is a new worm infection. Mode of transmission, here the larvae, they are going to penetrate their body through the skin, and that is barefoot walking or something like that from contaminated soil. So first it leads to a ground itch, then there is intestinal stage where there is a diarrhea and abdominal pain. Apart from that, because of blood loss, there is going to be iron deficiency anemia. Then in investigations are stool examination. In the stool examination, we see a hookworm ova. Then treatment is albendazole, mebendazole, and iron supplements. Prevention is by sanitation, wearing of footwear, and proper disposal of feces. A very important topic, that is HIV and AIDS. So human immunodeficiency virus, HIV, it is an enveloped RNA virus. It belongs to Retroviridae family. It is a spherical virus, and from the Retroviridae it belongs to Lentiviridae family. It measures about 90 to 120 nanometers in diameter. Then the viral core, it consists of major capsid protein, that is P24, which is a diagnostic antigen, and nucleocapsid proteins. Then there are 2 identical copies of single-stranded RNA and 3 viral enzymes. The 3 viral enzymes are RIP, that is reverse transcriptase integrase, and protease. Reverse transcriptase is a RNA-dependent DNA polymerase. Then the nucleocapsid, it consists of P17, P24, matrix 14. A lipid envelope is there outside it, and it consists of the glycoproteins 120 and 41. Glycoprotein 120 is in the form of external knob-like structures, while GB41, they are anchoring, helping anchoring. Then the genome, it consists of standard retroviral genes like the GAG gene, whole gene, and the ENV for the envelope gene, and regulatory genes as well. The mode of transmission. So modes of transmission is by the exchange of the body fluids containing virus or infected cells. So the major route is sexual transmission. So heterosexual transmission is the most common worldwide, but however the chances of getting transmitted are more in case of homosexual route. Then there is a risk increases by genital ulcers like the syphilis, chancroid, STDs, uncircumcised, and rectal laceration. So these are the conditions, that is prevalent STDs, they lead to a rise in HIV transmission through sexual route. Apart from the parental transmission, it can be via the IV drug abuse, that is shared needles, blood transfusion, needle prick injuries, or mucous membrane splash. Then perinatal transmission can happen in utero, that is transplantal, or during the delivery, intrapartum, or during the breastfeeding. Also the transmission can happen. It is not transmitted by casual touch to someone or through the saliva, tears, or through the insects. Then the pathogenesis and the life cycle. So the infection, the HIV, it binds to it binds via the GP120. GP120 is the glycoprotein which has knob-like structures. It binds to the CD4 receptors which are present inside our body, that is CD4 T cells, monocytes, macrophages. It requires co-receptor, that is CCR5 or CXCR4. It reduces conformational change in the GP41, that is anchoring protein, and that leads to membrane fusion and viral entry into the T helper cells. Now integration, this reverse transcriptase, which is a RNA independent DNA polymerase, it starts functioning, and the single stranded RNA gets converted into a double stranded DNA. It integrates is the enzyme that allows the integration into the host genome, and finally the replication happens. So there is a latent infection, that is, it is silent for months or years, and then it produces infection by transcription. Viral replication happens within the host cell itself, and host cell death finally happens by the budding of new virions. And dissemination, it disseminates by the lymphoid tissue, leading to viremia. So clinical staging, there's 4 stages. So stage 1 is asymptomatic, where there is a lymphadenopathy that can be present. Stage 2 is minor mucocutaneous manifestations, recurrent upper respiratory tract infections like pneumonia, wet pharyngitis. Then stage 3 is where unexplained diarrhea is present, severe bacterial infections, oral candidiasis. And stage 4 is AIDS defining conditions. So in stage 1 will be asymptomatic. Stage 2 is where minor mucocutaneous and upper respiratory tract infections are there. In stage 3, the diarrhea and all those features are there. So we have the oral candidiasis. In stage 4, AIDS defining conditions are present. So CDC classification is based on CD4 counts as well as symptoms. Now very important is the CD4 count. CD4 count defines the opportunistic infections and the malignancies that can happen in AIDS. So if the CD4 count falls to less than 500, the most common organism is the Mycobacterium tuberculosis, leading to tuberculosis. Then herpes zoster virus, oral thrush, that is candidiasis, and Kaposi sarcoma that can happen. If the CD4 count falls to less than 200, then we have already studied the pneumocystis carinii pneumonia and esophageal candidiasis. Then CD count of less than 500 will lead to oral candidiasis. Over here it will lead to esophageal candidiasis. A count of less than 100 will lead to cryptococcal meningitis and toxoplasmosis. Of less than 50 will lead to cytomegalovirus infections, CMV retinitis, and disseminated MAC infection, that is Mycobacterium avium complex. AIDS defining cancers, they include the Kaposi sarcoma, that is human herpes virus, the non-Hodgkin lymphoma, which is caused because of Epstein-Barr virus, and a cervical carcinoma, HPV. And the diagnosis, so the serology ELISA screening can be used for the screening, while the Western blot method is used for the confirmation. Then detectable antibodies are seen 3 to 12 weeks post-infection, but the P24 antigen that appears before, so P21 PCR can be done for this. Similarly, PCR for HIV RNA to find out the viral load, as well as monitoring of the CD4 count. It indicates the immune status, and the viral load is important because it predicts the progression and prognosis as well. Then management, so antiretroviral therapy is given. The goal of antiretroviral therapy is not cure, because HIV is not curable till now. It suppresses the viral replication and it restores the immune function, prevents the further transmission. Now indications is all HIV positive individuals, irrespective of the CD4 count, should be given antiretroviral therapy. The classes are nucleoside reverse transcriptase inhibitors, that includes the zidovudine, lamivudine, tenofovir. Then non-nucleoside, that is NRTIs, that include the nevirapine, efavirenz. Protease inhibitors, that is lopinavir, indinavir, ritonavir. Then integrase inhibitors, raltegravir, dolutegravir, and entry of fusion inhibitors, that is enfuratide and maraviroc, which acts against the CCR5. So the preferred first line regimen is TDF, is the TLD, that is tenofovir, lamivudine, and dolutegravir. In case of children, it is TLL, that is tenofovir, lamivudine, and lopinavir and ritonavir. that can be given. Then treatment of opportunistic infections for pneumocystis caries pneumonitis, cotrimoxazole, that is trimethoprim and sulfamethoxazole, cryptococcal meningitis, amphotericin B and flucytosine is given. For prophylaxis, 5-fluconazole is given. For cytomegalovirus, ganciclovir can be given. And for TB, start the antiretroviral therapy within 8 weeks of TB treatment. So, our first TB treatment is started, then antiretroviral treatment is started. Then prophylaxis is for if the CD4 count less than 200 is seen but there are no pneumocystis caries pneumonia, then cotrimoxazole can be given for prophylaxis. Apart from that, pentamidine can also be used, and the MAC complex for that azithromycin is given. Then prevention and post-exposure prophylaxis in case of healthcare workers, it should be started within 72 hours of the exposure, and regimen is tenofovir, then emcitabine and altegravir, that is given for 28 days. For pre-exposure prophylaxis for high-risk groups, tenofovir and emtricitabine are given. And prevention of mother-to-child transmission. So mother-to-child transmission prevention is by ART, antiretroviral therapy during pregnancy, elective C-section, avoidance of breastfeeding should be done. Then complications are high risk, that is immune reconstitution, inflammatory syndrome, and where paradoxical worsening can happen after starting the antiretroviral therapy. Apart from that, HIV associated nephropathy, that is HIVAN, and HIV associated neurocognitive disorders leading to AIDS, dementia. Prognostic markers are CD4 count, the viral load, and rapid progressors are where the CD4 decline is more than 50 per month after seroconversion. Then certain population is found in the Scandinavian countries where they maintain a high CD4 count and undetected viremia even without ART. So these are considered to be long-term non-progressors or relay controllers. Then talking about Kaposi sarcoma, that is human herpes virus 8, it's a AIDS-defining malignancy. Then it involves the skin mucous membrane as well as the viscera of the organs. The skin lesions appear as erythematous or violaceous macules, papules, or nodules. The visceral involvement, it leads to GI bleeding, respiratory symptoms, lymphadenopathy. Diagnosis primarily clinical in nature based on the characteristics, skin lesions, and anemia due to bleeding. Then apart from that, biopsy confirmation shows the spindle cells, slits, and extravasated RBCs. Treatment is, if it's a localized disease, then radiotherapy is given, cryotherapy can be given, and intralesional vein blasting can be given. If it's extensive or visceral disease, then the therapy should be started with liposomal doxorubicin, paclitaxel, or immunotherapy with interferon alpha. The initiation of ART is essential as immune reconstitution can lead to regression. Then the cryptococcal meningitis. So cryptococcal meningitis is the most common meningitis that is seen in the AIDS patient. It is caused because of Cryptococcus neoformis. It typically occurs when CD4 count is less than 100 cells per microliter. So the clinical features, it has got a subacute onset with headache, fever, nausea, vomiting, minimal meningitis, that is neck stiffness may be absent as well, and it may present as an increased intracranial pressure leading to visual disturbances, cranial nerve palsies can be seen. The diagnosis is by lumbar puncture. The opening pressure is high. Then lymphocytic leocytosis is seen, low glucose and elevated protein. Then CSF streptococcal antigen test can be positive. India stain or nigrosin stain can visualize the encapsulated cells, and CSF culture that confirms the diagnosis. So basically, we use the antigen test, India test, and the CSF culture. Serum cryptococcal antigen can also be positive. Now, treatment for the induction, we give amphotericin B and flucytosine. Then consolidation phase, we give 5-fluconazole, 400 milligrams per day. Secondary prophylaxis is by fluconazole, and the management of raised ICV, it can be therapeutic lumbar punctures, acetazolamide or VP shunt can be done if needed.